The idea is to share a clinical case, and I'm sure that we are different practice, and so it's an occasion to talk about this, and so feel free to interrupt me as when you want, and to ask a question. And so it's a young guy, 20 years old, and he has an accident of motorbike in Paris on the loop, and as you can see, during the pre-hospital phase, the Glasgow Coma Scale was equal to 6. He has an increase of heart rate, and the systolic arterial pressure is at 114, and with a diastolic arterial pressure equal to 51. The saturation is equal to 92 after 6 liters per minute of oxygen. And during the pre-hospital phase, the hemoglobin is equal to 13, and obviously there is an open fracture of the wrist, and so the pre-hospital team decided to intubate the patient and to start a sedation, and also they give antibiotic to this patient. So 45 minutes after, the patient were at the hospital, at the emergency room, and you can see that concerning the hemodynamic, the heart rate was still high, with a systolic arterial pressure which was low. The systolic arterial pressure was equal to 87, and the diastolic was equal to 49. The patient were ventilated with FeO2 equal to 1, and the hemoglobin, there was a drop in hemoglobin at 10 grams per deciliter, and with an increase of the lactate, and the PO2 was equal to 189 millimeters of mercury, with the PCO2 equal to 60. The temperature was equal to 35. And so during the pre-hospital phase, the patient received 5 milliliters of saline, and we pursue this and we give 1 liter of saline. But as it failed to restore arterial pressure, we start norepinephrine, and it was not very efficient. And we perform the echography. The echography shows that we had fluid in intra-abdominal fluid. We can see that we have contusion at the lung, and we perform a transcranial Doppler. I don't know if you know exactly or you are used to, and if you know, we use a pulsatility index, and the pulsatility index is when it's higher than 1.4, we consider that maybe we have to face to a cerebral edema. So it was the case in this patient, because we have on the right arteries 1.5 and the left one 1.4. So we were for instance faced to maybe an hemorrhagic shock and maybe an increase of the intracranial pressure. We perform a FIB test with the ROTEM, and we observe a decrease of the FIB10. So it's a suspicion of a decrease in fibrinogen. So we go to the CT scan, and I don't. Yes. So I will show you the CT scan after, but at this time, the first question is what is, in your opinion, what we have to do, because the patient is unstable. I have this doubt about the brain injury. So you have your surgeon at your side. Do I have to go to the operating room, or do you have to go to stay in the ICU because my emergency room is close to the ICU? Or do you have to go to radioembolization, or is it possible to go to do a CT scan? What do you think of this? What is your feeling about this?
Okay, can we vote on that? How many people have actually got the app on their phones? Probably a minority. Should we move to hands?
Okay.
Okay, so option one, who would go to the operating room with this unstable patient? Okay, so a significant minority. The ICU? One or two? CT scan? Yeah. And what about to IR, interventional radiology? No. Okay, so we're fairly, there's a small group of people that think the patient should go directly to the operating room, but most people think the patient should go to CT scan.
Yes, but it was practically equal between the operating room and the CT scan. So, so what we did is to go to the CT scan. So the discussion is the patient is unstable. So the option of to go directly to the operating room is really a possibility, because you have blood in the abdomen, the patient is unstable, the response to fluid and norepinephrine is not so evident. So really it could be an indication. We go to the CT scan for one reason, for several reasons, but we were concerned about the brain. So it is true that the priority is to stop the bleeding, but it's also very important to clearly have an idea of what is ongoing at the level of the brain, what we have. And if it's the edema is very important, it's important to have this in mind, to be able to control the intracranial pressure during surgery. It's why it's one of the arguments we push us to go to the CT scan even if the patient was unstable. The other argument is that it's very difficult to be sure that you have not another source of bleeding, especially at the retroperitoneum level, because the FAST is incapable to tell you if you have a bleeding at the retroperitoneal space. You are sure you have a bleeding in intra-abdominal bleeding, but you have this doubt, and it could be very complicated for the surgeon to stop the bleeding if you have both, or if you have only bleeding at the retroperitoneal space. When you have on your FAST, when you have an important quantity of fluid, it's the first option, it's intra-abdominal bleeding. But when you have a small quantity or moderate quantity, it largely could be a pelvic fracture with retroperitoneal edema and a suffusion of the blood at the level of the peritoneum. So it's, you have to keep this in mind, because it could be difficult after when you are in the operating room with the surgeon, and if the surgeon say, oh, there is nothing in the intra-abdominal space, it could be difficult if it's bleeding at the retroperitoneal space. Do you have question or comment on this? And feel you...
Yeah, so, I mean, I think it would be really good if we had some questions about, first of all, the early phases of care.
Yes.
Up to this point. Does anyone, I know there's nothing up on here, has anyone got any questions about the approach so far to the early phases of care? Yes?
Why antibiotics on fever?
Okay, that keeps the patient asleep, doesn't it? Joke. Okay, carry on.
No, because yes, because it's an open fracture.
Yeah.
And so we, the pre-hospital team in France, they do this. They immediately they start antibiotic. Not you.
Yeah,
Why?
I think that,
Okay.
I think that does vary in different countries. Most people have antibiotic guidelines, and certainly we would give antibiotics early. So, any other questions? I've got a couple. Okay, so saline pre-hospital for someone with hypovolemia and becoming unstable. Do you think there's a role for pre-hospital blood?
Oh. Just go back to the initial hemodynamic. You can see that the hemoglobin of the patient initially, it seems not so bad. But we have to keep in mind that in a young guy, the normal of hemoglobin is maybe more 14 than 13. So 13, and we do a study on this, 13, it's low. It starts to be low. So we have to be concerned about this. And initially, only on the first hemodynamic evaluation, for me, my first option is to go as quick as possible to the hospital and not waste time waiting for red blood cells. But it could be different depending if your patient is far away from the hospital, or depending of, for example, if it's a crash accident and he is stuck in the car, and we know that he will take time to deliver the patient. So if I observe that the hemoglobin is decreasing by repeating a measure, maybe I can order blood. But once again, the team has to be trained with this. And
So obviously you're doing point of care testing on scene with hemoglobin. Do you think there are any other point of care testing things that are useful in the very early phases of trauma, apart from hemoglobin? Blood gas analysis or anything like that?
Yes, I think it's a plus. Yes, it could be. It could be.
Because presumably all of these things are contributing to the pre-hospital time.
Yes.
Sorry.
The other question, saline on the field, why not balance crystalloids? The patient is in arrival, is in metabolic acidosis and lactatemia. Why use saline on the field when you know that it will induce hypochloremic acidosis in patients?
Very good question. No, it's a good question. It's a good hypothesis, but you know, we use many times saline in this trauma patient, but clearly it's a good option, and we are starting a trial on this, comparing saline to balance fluid. And isotonic balance fluid, for sure. But it's a very good question. But there is nothing in the literature right now in trauma patient. Nothing. But it's a very good hypothesis.
Okay, gentleman there.
I think the saline is explained, probably. The other question is...
Sorry, could you repeat your...
I think the saline is okay because it's probably a head injury patient, and in that case, saline is recommended at the moment. The other thing, which it's not clear for me, more than or almost 1 hour has gone, and the patient had only 1 liter of fluid. And I think that's not enough. Maybe the patient would have been stabilized if he would have had more, and then it would have been easier to decide whether to go to the CT or whether to go to an operating room.
Yes. The first remark about saline, and once again, balance, isotonic balance fluid. I think that isotonic balance fluid, isotonic, it could be a good indication in brain injury. So, but once again, it's just to, most of the time we use saline. The second comment is maybe the guy is hypovolemic and maybe we did not give enough fluid. It's because we are always concerning to give low fluid. And maybe it's an excessive strategy, and maybe sometimes we don't give enough fluid. I'm completely agree. And maybe it could explain why the patient is still hemodynamically unstable. And the way to test this, sometimes it's very difficult because we target our resuscitation on arterial pressure. And arterial pressure is different from cardiac output. So maybe it's not a very good indices. But we perform in the lab a study on this, and looking at, during the initial phase, the arterial pressure, the cardiac output, the tissue perfusion, and during the initial phase, the arterial pressure is not a bad index of cardiac output in patients sedated. So I think that maybe it's impossible to exclude the fact that maybe the guy is still hypovolemic. I'm completely agree.
Hello, Paul Abraham from France. Can you comment on early initiation of vasopressor in those specific polytrauma patients with new, for example, data in the literature and stuff like that?
Yes. So it is true that we are used to very quickly use norepinephrine. And it's, for example, in my unit, if we have no response after 500 or 1 liters, we introduce norepinephrine. The idea is the patient is sedated, so we decrease his capability the capability of the sympathetic tone, and the idea is to restore the sympathetic tone, and by this way also to give less fluid and to induce less hemodilution. So there is very nice experimental study showing that we are not deleterious with norepinephrine, but concerning clinical study, there is nothing proving that it's a good strategy and proving that you decrease, for example, mortality by doing this. But there is some study, a retrospective study, looking at is it harmful or is it beneficial, and US study shows that it could be harmful. So there is an ongoing debate around this, but when you look at the study, the quality of the study, it's very difficult to have a clear idea. And right now we are still in this strategy. I don't know if there is a good trial ongoing on this topic. Maybe. There was a trial on vasopressin in UK, but they stopped it because they had a problem to include patients. But they show that they were able to decrease the quantity of fluids that they have to give. And it was not possible to conclude on mortality because not enough patients. So the question is still in debate, but it is true that I think that if you start quickly norepinephrine, and if when the bleeding is stopped, you decrease quickly the norepinephrine, and you are deeply concerned about the volemia of the patient, I'm sure that it's beneficial.
I think that's really interesting because in my experience in the UK, we treat patients like this differently in the pre-hospital environment and the emergency department than when they go to theatre. In other words, anaesthetists are very familiar with the concept that when you start positive pressure ventilation and give anaesthetic agents, patients become hypotensive, and they try and reverse that with vasopressors. But in the pre-hospital environment and the emergency department, the idea that if a patient is hypotensive, then they're hypovolemic until proven otherwise tends to be the dominant strategy. And of course, they are the same patients, just in a different part of the pathway. So maybe we should be treating them the same.
Yes.
Yeah.
So the idea is for me, when we talk, for example, about damage control, to introduce norepinephrine, it's one element of the damage control, because when you introduce norepinephrine, you have to give less fluid, so you have to induce less hemodilation. And it's a short period. Most of the time we stop the bleeding after 2 hours of management of the trauma. So when I look at the duration of norepinephrine in our patient, it's 3 or 4 hours of norepinephrine. And you can see that the lactate decrease when we stop the bleeding nicely. So I'm not anxious about deleterious effect of norepinephrine, and I think it's more an help than nothing. And what I saw in the UK recommendation, it's the level of arterial pressure is in some recommendation is very low. It's so I'm always afraid of cardiac arrest because we say don't give too much fluid. But when you have an hemorrhagic shock, you have to give fluid. So if you don't give a lot of fluid, and if your target of arterial pressure is very low, I'm afraid that there is a high risk of cardiac arrest. It's my feeling.
Do you think the problem is around the fact that blood pressure is a poor marker of organ perfusion, and we should be using other things to look at organ perfusion, like tissue saturation or something along those lines?
It will be great, but the problem is that most of the time we have so many things to do when we have to deal with an hemorrhagic shock that it's difficult to have, for example, cardiac output. We use, when the patient arrived, sometimes we use esophageal Doppler because it's not very difficult to insert. And we insert very quickly arterial catheter. So it's possible to monitor cardiac output by this way. But it is true that during the initial management, we deal with heart rate and arterial pressure. And it will be great to have an evaluation of tissue perfusion. We use a lot lactate for this, but I think we can do better. I agree with you.
So, yeah.
Okay, 2 questions. Do you have echocardiography in your emergency services?
Yes.
Yes, you have that possibility. So that would be a possibility to check with the echocardiography to see if the patient needs inotropic support or if the heart is empty,
yes,
actually. And the second question, midazolam for intubation. In Finland, our emergency services have started using, because of the London HEMS, they have started using ketamine. And,
okay.
Yes.
No,
we're not sure if it's the good path, and I would like to have your comments. What
yes,
do you feel about it?
The first comment is we have echocardiography, and we perform echocardiography a lot to evaluate, to have successive evaluation of the heart. And so when we perform at the admission the ecography, it takes 10 minutes to do the transcranial Doppler, to do the lung, the abdomen, and to check the heart. And because we want to exclude pericardial effusion, and we want to have a quick look on the contractility, and we have a quick look on the vena cava, just to have a quick evaluation of the volemia. Even if we can discuss, because it's not always accurate. But, you know, in this kind of patient, it's very exceptional to have a cardiac dysfunction, except when you have a high intracranial increase in intracranial pressure, because in this case, you can have clearly a myocardial dysfunction. Your second question, it was?
Ketamine.
Midazolam for intubation.
Oh, okay.
What is your opinion about ketamine in intubation on the field?
Yes,
in an
we have.
unstable patient?
Yes, we use most of the time in emergency. We use. There is a discussion about etomidat, but we use ketamine or etomidat, and more ketamine to intubate the patient.
Yeah, I mean, I think we've spotted we use midazolam as part of our sedation protocol, and we have seen quite a lot of cases of covert hypovolemia revealed with too high doses of midazolam, particularly in the elderly. You know, even 2 or 3 milligrams can cause quite a response. I'm not the biggest fan of ketamine, but we do use it, and I can't really think at the moment of anything better. I think all of the air ambulances in the UK use it. And obviously we've been influenced to some degree by the military experience over the last 10-15 years, where ketamine is pretty much the only agent that's used. So, gentleman there.
Well, Jacques, as a surgeon, this patient is bleeding.
Yes.
So where should this patient be? I think in the operating room, because one of the things we should do is stop the bleeding. And you're perfectly right. What we have to do is to have a bridge to that surgery. And if you have intubated this patient and you've given him midazolam, perhaps a little bit of norepinephrine would be needed to get to that surgery with a nice level to counteract the deleterious effects of all the medication we gave. But this patient should be in the operating room as soon as possible to stop the bleeding. If you see what kind of lesions this patient has, it should have been, you should say 10 minutes of doing all those stuff. In those 10 minutes, we have the patient opened and packed in the OR. And if in that situation, in your shop, that isn't the case, you should educate your surgeons.
So, I agree with you, but not completely. So, and it's why it's very interesting to discuss about this. This guy has to go to the operating room, but you can miss something easily, which could be easily performed at the level of the brain. And it's just, for me, a very important argument to do the CT scan as fast as possible to see if we can, it's not possible to perform a drainage and to be sure to control during the surgery, to control the intracranial pressure, because at the same time you stop the bleeding. The patient is an inflammatory patient, and the inflammation can increase the intracranial pressure. So the risk is that we stop the bleeding, but the risk also is that the patient had a very high intracranial pressure during this procedure. It's just to try to treat the two lesions.
Depends very much on what the reaction of the patient is. If you have a responder, then you have the time to do the CT. And of course, you have the right situation on your side, given the studies in the Lancet that have been published out of Germany. But that's a completely different situation. The other thing is that low blood pressure is initiating even more the immunological situation of the patient. And we've shown that the immune response of the patient depends more on the low blood pressure than doing a right operation at the right time in the earliest phase. And we've seen a decrease of all those later problems with a very early stopping of the bleeding. So I think that should be in the first place. That also is helping your brain, because with a CO2 of 60
Yes.
And a bleeding patient with a low pressure, you are adding into the problem of the brain. So it would be more adequate to go to the operating room, do a quick laparotomy, pack the patient, and go then to the CT, and then do the necessary other things.
Yes.
If the patient has a blown pupil, that's a different thing.
Yes, but one thing is, and it's very important to focus on the CO2, because the CO2 will increase the brain edema. So it's very crucial to be focused on this. And I indicate this, it's a real case. I indicate this because most of the time it's difficult to be sure that you control properly the CO2 during the pre-hospital phase. And it's so important for the brain that we have to be very concerned by this. Another point is by using the transcranial Doppler, which is it's not very complicated, but with this value, I'm practically sure that I have to phase II edema. So it's one argument to go to the CT scan, but I understand your point of view, and it's a different strategy, but...
Should we move on?
Yes.
Yep.
So here is the CT scan. So on the CT scan we have a bilateral petechial hemorrhage with a cerebral edema, an important cerebral edema. At the level of the thorax we have a bilateral pulmonary contusion and a bilateral minor pleural effusion. The abdominal CT scan show an hemoperitoneum with a splenic laceration, with a subcapsular hematoma and a blush, and several hepatic laceration. At the level we have also orthopedic injury with a closed tibial plateau fracture and an open fracture of the wrist. So we saw this. So what is your transfusion strategy in this patient?
Okay.
So there is only one response, which is correct.
Yep, so we're going to vote on this again. So who will go for number 1? 2 red blood cells and 2. Not very many. Really? No one wants to give blood? Scattering of people. Okay. Platelets? No one? Fibrinogen? Yeah. No tranexamic acid? That's, yeah. Okay, so most people want to give fibrinogen and a minority wants to give some blood.
Okay. So it's the right response is fibrinogen. We have to give blood, but as there is only one response, we have to give blood, but we are sure that we have to face to an hemorrhagic shock. So I don't know how is it in your unit, but for example, in my unit, when we have to deal with an hemorrhagic shock, the first order is 4 red blood cells, 4 FFP. So in some units it could be 6 and 6. So it's clearly a strategy 1-to-1. And so I think that to order 2 red blood cells or 2, FFP, I'm sorry, it's not enough in this case, because we know that we will have a very difficult period when the surgeon will open the abdomen. Do you have comment on this, and what is your practice on this? What is your first order of red blood cells?
I would give tranexamic acid first.
Yes.
Maybe on the field. Then
exactly.
Fibrinogen in the shock room, in the emergency room. But my question is, we spent 15 minutes from arrival to the hospital to getting the CT scan, and we have a patient who is highly unstable and is bleeding.
Yes.
So I think the time is not the best.
Yes, the time is not the best, and I'm happy with your remark, because it's really crucial to take in time and to not lose time. But you know, when you check the real time, you are always surprised. And So, for example, in Paris, we have a register, and so I look at the mean time for a patient to. In Paris, we have physician on the ambulance, but the mean time between the trauma and the arrival to the hospital, it's 80 minutes. So it's huge. It's huge. For me, it's huge. But everybody think he is not losing time. And when a surgeon say it takes for me 10 minutes, if I look at the time in my hospital, maybe my hospital is the worst in the world. So it's possible. I do not exclude this, but it's take every time longer than you think. And we have to make, and it's why I put the real time, we have to make effort on this to really do only the essential things to do. So I'm comfortable with the discussion about the CT scan and the direct operating room. It's different choice, and in this case it was not deleterious. But I think that we have to be very modest, and each time to review the time we spent at different area in the emergency room, in the CT scan, during the operating room, and to be very focused on this.
So I'm just going to comment on, I think it is a long time, and certainly for penetrating trauma, we try and get them through much quicker, but 15 minutes is not actually, I don't think if you looked at all of the hospitals and these patients, actually 50 minutes is not that bad at all. I just wonder, you have physicians in your pre-hospital environment. If you have a physician that's been looking after the patient for a period of time and knows how stable the patient is, what do you think of straight to CT policies? In other words, the patient comes in and the handover to the trauma team done is in the CT scanner. We have a number of our trauma centres that do that.
I think it could. The problem is your organization has to be very rigorous and very smooth. So you can have different options. If the best option is to go directly to the CT scan, it could be the good option. We don't make this choice because we think that it's important to have really very quickly a clear view of the patient by performing echo and to be able to insert catheter. But if the CT scan don't take a long time, and after you take in charge your patient with a complete view of the patient after the CT scan, and it's well organized, it's okay for me. It's okay. It could be even better than other option. I know that in Germany they have this kind of strategy, and it's a good one. Everything that waste where you don't waste time is a good option. So
Okay.
its organization is crucial.
Should we move on?
Okay. So this is after the CT scan. It's so we have 2 microgram per kilogram per minute of norepinephrine. We did tranexamic. We start the transfusion, and we are going to the operating room. So my question is, I'm afraid about the cerebral edema. So to prevent a decrease in cerebral oxygen delivery, do you start mannitol? Do you increase the mean arterial pressure, even if you can increase the bleeding? Do you enhance lung protection? Do you target value of hemoglobin within 7 and 8? And ask to the neurosurgeon to perform an external ventricular drainage.
Okay, so number 1, start mannitol. Anyone? Number 2, increase the mean arterial pressure to 80. Yeah, that's got some interest. Number 3, lung protection. Number 4, target values of the hemoglobin 7 to 8. And lastly, asking a neurosurgeon to put in an EVD. That's not a very popular option. Okay, so
Yes.
there
So
we go.
it's, you have to increase the mean arterial pressure. So this is clear, but you know, it's clear, it's recommended, but it's very, very difficult when you have to deal with an hemorrhagic shock. Very difficult. And I think the mistake is to try to get this target by given fluid. It's too high. It's really too high. And you can, maybe by increasing norepinephrine more, you can get this, but it's very difficult. I think the best way to do is, it's what we do, is to redo transcranial Doppler and to see if what is the good level of arterial pressure to get a good velocity at the level of the Doppler. It's the best way to be balanced between a very high level of arterial pressure and to a good arterial pressure and not to increase too much the bleeding. So I think it's a good way to do, and it's a more realistic way than the recommendation, because the recommendation sometimes it's very, very high arterial pressure, very difficult to get.
What do you think about the inter-observer variability of TCD determination?
Sorry?
The variability between different operators for
okay.
TCD.
Okay. Depending on how your team is trained about this, but you know, there is variability, but when you have a pulsatility index greater than 1.4 with low diastolic velocity, you are sure that there is a problem. So really, the variability, when you try to know, do I have or not a cerebral edema, it's not a problem. It could be a problem for when you have not cerebral edema, but we are not to face to variability in this case.
Yep.
You prefer to do the repeated TCD monitoring, but how about to ask a neurosurgeon to put in an ICD monitor?
Oh.
Then you see the online. I know that in our hospital, this patient probably would have in the emergency department already right after the CT scans the ICD monitor inserted and then.
Exactly. I'm completely agree with you. But what we do is that in this case, this patient has to have an intracranial pressure, but we just wait for the hemostasis, to have a correct hemostasis, to be sure to not induce a cerebral edema when we insert the catheter. And the other thing is that the surgeon will be occupied with the bleeding, but the neurosurgeon is ready to insert the intracranial pressure when we are sure to have a correct hemostasis. So we have a very, it's easy to have very quickly an intracranial pressure, and it's and the fact that with the CT scan we can immediately alert the neurosurgeon that he will have to insert the intracranial pressure. Concerning the drainage, so it's not you can see that looking at the CT scan, there is no indication for a drainage, but sometimes a drainage could be very efficient to control intracranial pressure and to pass this period. So you have to, with the neurosurgeon and the surgeon, we will stop the bleeding to just discuss what is the right time to insert intracranial pressure or to do ventricular drainage. But what is great is that it's my, with the CT scan, everybody is alert about the fact that we have the combination of an hemorrhagic shock and a CT and brain injury.
Jacques, I thought that we'd get through this case pretty quickly. I think the lesson is that we found that early trauma care is a little bit more controversial than we thought, and we're actually out of time. So do you want to just say a couple of words to close us off?
No, it's a pleasure. I think that what is important, and it's great to discuss of this at the European Society, is that we have different way to do, and because we have different organization. And but it's great to share this, because I once again, in each country, in each facility, there is something to pick up and to improve your way you manage this patient. Thanks a lot.